Welcome back to CGM Sweet Talk with the Sugar Queens. This is episode 3 of season 2. We so appreciate all of you and what you do. And we're glad to see you again for some sweet CGM talk. I'm Dr. Eden Miller, an osteopathic board certified family practitioner, a diabetologist, and obesity medicine specialist from Bend, Oregon. My queen, Jen.
Hi, everybody. Nice to see you. Thank you for joining us. My name is Jen Goldman. I am a professor of pharmacy practice at Massachusetts College of Pharmacy, where I teach in the pharmacy and the physician assistant program. And I direct the cardiometabolic services at Well Life Medical. And so that's in Boston and north of Boston, Peabody, Massachusetts.
And I'm Davida Kruger. I'm a certified nurse practitioner in Detroit, Michigan, and I am just so thrilled to be back again.
Yes, great to have everybody back. And for the next 25 minutes, we're going to discuss one of my dear patients, Angie, who transformed her diabetes care through GLP-1 receptor agonist therapy, coupled with our favorite CGM. So we want this to be interactive. We know that many of you are coming today to get some great education, but we want you to put your questions in the chat. We're monitoring it. We're there. We're going to try to get to many as we can, but we can also incorporate it during the program as well. Okay, with that, let's get going. Let me introduce you to Angie. She is a 42-year-old Asian American female who owns her own business. She's an amazing hairdresser. She was diagnosed with type 2 diabetes about 5 years ago. And you know what? She had an A1C presenting as 14. Yes, queens, I worked her up for type 1, right? I know you're thinking that. I totally worked her up for type 1. Didn't want to miss that. When I first saw her at my office, her A1C was 8.8. She was on glipizide, cringe, and dulaglutide, but she was really intolerant to metformin. And she does remember using basal insulin kind of initially, right? When she had her really, really high glucose at diagnosis. She already has mild retinopathy after 5 years. And she had an elevated UACR with 42 and an EGFR right about 60. So she was that 2A2, right? That stage for her kidney. And I asked her, I said, what were some of the goals for care? Because, I was meeting her, of course. She said she wanted to improve her A1C, but she also wanted to improve her weight. Now, remember, she's an Asian American. Her BMI was 28, but as you know, that culture, they can't have any excess weight on it. Just really contributes to that insulin resistant. Okay, Davida, start us off. Thinking about the standards of care, because they've kind of changed a little bit, how are we going to clean her up a little bit? What would you start doing?
Well, first of all, I think I really want to remind people that in an individual like this, who already has complications at 5 years, with an A1C as high as you have described, she's had diabetes for a long time before she was diagnosed. And we know that could be 7 or 8 years, but perhaps she was even longer. And that kind of breaks your heart as well. So, standards of care are telling us that we should avoid medications that cause hypoglycemia. That would be sulfonylurea. From my only perspective, I really think they're just nasty because they cause hypoglycemia and weight gain. And I know they're cheap, but we shouldn't be using them from the get-go. The get-go is metformin and probably GLP-1 or GLP-1 GIP and or SGLT2 inhibitors. So that's really how standards of care. The other thing is she's on a GLP-1, but perhaps we could give her a newer GLP-1 that might be a little more potent for her. That might be helpful. So I would get rid of the sulfonylurea and think about a more potent GLP-1 or GLP-1 GIP.
That's funny that you said that, because I told her I was going to give her a fresh up, just like when we go to the hairdresser, right? Okay, Jen, are you still seeing this float by? Are you still seeing providers choosing medications that are not aligned with that standard of care?
Like see no evil. Yeah, absolutely. So despite the ADA standards of care and ACE guidelines clearly prioritizing the GLP-1 receptor agonist and SGLT2 inhibitors for patients with ASCVD or obesity, or so
Mm-hmm.
kidney risk, like this patient, right?
Red
So this
flag.
many providers that they are still writing for sulfonylureas or DPP-4 inhibitor first, and sometimes it's habit, sometimes it's cost or formulary access, or just not knowing that these drugs are available and on people's formulary. But we really need to shift practice toward outcome-based prescribing and using CGM as a guide and not just the A1C. So we know sulfonylureas, like Queen Davida just said, cause weight gain and they cause hypoglycemia. I haven't written a prescription for a sulfonylurea for at least 15 years. My patients aren't different than anybody else's patients, so it can certainly be done. And it's certainly not when we have so much, glycemic and proven pleiotropic effects from these preferred agents.
For sure. Well, you know what I did, because I gave her a medication makeover. I immediately stopped the sulfonylurea, to your point. And I always say, what is that med doing for me?
Yeah.
What is the sulfonylurea doing for me? It's doing a lot against me, and it's doing a lot against for that person. And I added an SGLT2. I added it for purpose, right? The purpose was to improve her kidneys. And I did exactly that. You guys, we know each other so well, we can finish each other's sentences. I added a different GLP-1, GLP-GIP with a little bit more efficacy. And Queens, what else did I do for her?
CGM.
Shocker, right? Of course I did. Now, why did I do CGM? I did it because she said she wanted to engage in her diabetes. I want to know, I'm making a makeover with her meds. I want her to see how it affects it. I want her to learn about lifestyle. We talked about previous Queen's episode about weight management and dietary interventions using CGM. I was going to give her what we have been talking about episode after episode after episode. Okay, so let's look at her baseline. So I have her baseline. Now, what are you seeing, Jen? What do you see top of line, right? All of us online can see this. We want you to look and say, tell me what you see.
So everybody, take a look at this. Her AGP report shows this broad glycemic variability of 56, that up for the standard deviation, with such a significant time above range. So if you look at the total high and very high, it's 89% actually. So when you add them both together, so truly suggesting obviously suboptimal medication selection, and possibly but she has not been using CGM, really no insight into, real-time glucose awareness and lifestyle impact. So glipizide likely caused some of those postprandial swings, but without CGM, these excursions are invisible. Nobody would know.
Yeah. And Davida, talk about how much time and range she has right now, right?
Is there any? I'm trying. I'm looking. I have to put my glasses
I know.
on.
I think we're in almost like barely double digits. Yeah.
I actually think that in general, the medication she's taking just isn't enough, of course.
No.
Because she's spending her life in the sky. The poor woman is probably thinking, right? The woman is saying, I'm
in the clouds.
Right, in the clouds, in the sky with those clouds up there and the poofy stuff. So the problem is she is not even touching the bars of treatment goal. And she's taking a once weekly, and she's taking the sulfonylureas. Now, she has come down from 14 to 8.8.
Well, yeah, good.
And she's working hard, I'm sure, at this. So, I mean, it's really awful that we have to do better. And I know you will do better. I have done better for her. But yeah, all I see is a bunch of glucose in the clouds.
Yeah, for sure.
Aiden, what did she tell you about her lifestyle?
Perfect. Because she actually said, as you can see, she doesn't eat much during the day. That's another thing. You know, as you listeners, as you guys are looking at this, you see pretty consistent blood sugars during the day, right? And so I said to her, tell me about your day. I said, I can actually see it here. That's what CGM allows us to do. We look like we can see the future, right? Or we can just read their mind. But I said, I noticed you don't eat a lot during the day. She goes, I don't. I'm going from person to person. I'm doing I'm a hairdresser. I clinic. And when does she eat? She eats dinner. right? That's what she does. And so you're spot on, Jen. By looking at, you can see her lifestyle played out here. And I'm not here to come and shame and blame with it. It's just reality. So Davida, take us into a little bit of science. Talk to us about how utilization of CGM with GLP-1s is promoting better control, because we know GLP-1s are pretty amazing. So show us a little bit about that real world data.
Well, first of all, I think what I have learned over the last 3 or 4 or 5 years is that GLP-1s are phenomenal. Everyone should have a GLP-1 on board. The problem is it's not necessarily enough. And I think what happens is we add it, we sit back and we say, okay, job done. We know that's not true. The job is not done. And so the real world will show you that after adding CGM to GLP-1, which we think, oh, it's not insulin, it's not going to cause hypoglycemia. Why do we need it? We need it so that we can see what's happening with the data and the patient can make lifestyle changes. And we know that lifestyle changes can occur if we give them CGM. So in the study here, the real world study, there was an improvement of an additional A1C lowering of 1.5%. Improvements was seen on all GLP-1s. It doesn't matter which GLP-1.
Doesn't matter.
And we could talk forever on this one has that, this one has this, cardiovascular, kidney, once weekly, but I take what I can get from the insurance company and I go from there. And so didn't matter what GLP-1 the patient was on, they had an improvement in their A1C, and whether they were on insulin or non-insulin, we saw an improvement by just giving CGM. And I believe this is the study you were working on, Eden, as well. And then,
I set you up a little bit on that one. Sorry.
I see that's Miller et al. Would be you. Yeah. And then the other GLP-1 studies shows that initiating GLP-1 combination with GLP therapy. So if you start them together, they have a greater outcome. And then they're looking, the U.S. payer perception was that it's more cost effective when you add CGM to GLP-1 because of the benefit of the treatment outcomes. So even if they're not yet on GLP-1, it works doing a combination. But if they're on GLP-1, adding it to GLP-1 makes a huge difference in terms of the A1C. So they don't have to be on insulin. We've said that forever. Give the patient a CGM.
So Jen, I want you to walk us through what happened with Angie when we did exactly that. We went to the standards of care, we added an SGLT2, we switched around her GLP to give her a little fresh look in her incretin. So tell us, what do you see now? Walk us through.
Well, wow.
Right? And down, pushing it up.
And the other thing is, we kind of talked about before how data is power. And this patient having access to see it in real time, what the interventions are, really helps people. Just like, you talked about in the past, that attaboy and attagirl. It's really rewarding for them to be able to see it. So, a couple of things beyond the obvious of significantly improved time in range with a lower glycemic variability. So went from 56 to 22. We can see in real time and in real life with data the impact of choosing better drug therapy. So tirzepatide is superior to dulaglutide, and fasting and postprandial blood sugars are better. And removing that glipizide and adding DAPA, and DAPA specifically targets postprandial blood sugars, led to this meaningful improvement. And what's important, what we don't see here, is hypoglycemia.
Yes.
Right. So these agents are low risk for hypoglycemia. And this targeted efficacy is an example of why the guidelines that we just talked about do not support sulfonylureas for patients with type 2 diabetes, and rather drugs with proven and important outcomes. So in this patient, she has, kidney issues. So in addition to glycemic improvement, we have non-glycemic impact, weight loss, cardiac, renal benefits of these classes of drugs.
Yeah. And walk us through how, Davida, look at her BMI and her A1C, yet we're not having hypo. And look at the dose. Look at the dose of the tirzepatide.
Right. And so I think this is why you follow the standards of care. and why these drugs are so important to how we manage diabetes. They don't cause hypoglycemia. They do have a weight reduction with it. And as Jen already said, some of them help with kidneys. Some of them have cardiovascular. They all lower the A1C. They are phenomenal. Now, I will make one comment, and she was not tolerable. She could not tolerate metformin, because people say to me all the time, the standard of care do say metformin, and why do you care about metformin? I care about metformin because my insurance companies require me to try metformin to get to these medications, even if they're simultaneously. And if the patient does not tolerate metformin, it's fine. Just put in your notes, metformin was started, and at this dose, patient was unable to tolerate. And that will be helpful for you to get your SGLT2 inhibitors, and definitely to get your GLP-1s and GLP-1 GIPs. So that's really, really important. So this patient, not only she's now 98% time in range, no hypoglycemia, her BMI is down to 22. And remember, she's an Asian woman, and then her A1C is at 5.8. And not too long ago, it was 14%. So,
right.
And all you did was kick one drug to the curb and swap out the other one. Yeah.
I did a medication makeover, because you know what? Metformin is not queen anymore. She has retired because there are new queens. Jen, put your pharmacy hat on for me and talk a little bit about what we're getting when we add a GLP-1 and we're customizing it and we're using CGM. What are some of those extra things we get besides just efficacy? Talk us through that.
So we know they reduce A1C, the efficacy, but it supports weight loss. But that CGM gives patients the data to understand patterns, especially those transient spikes. And if they were having overnight lows, this patient was not. But together, using them together, they create a feedback loop. So the medication works, the CGM is telling them that. The CGM helps that patient fine-tune their lifestyle and reinforces adherence. So it's empowerment and efficacy working hand in hand. Data is knowledge. Data is power. So you cannot get this level of data and this level of information or power from finger sticks. It's impossible.
For sure, for sure. Now, Davida, we talk about standards of care for the ADA4 technology, but remind us again, top of line, because I still don't think the message is getting through. We still see this bias or myth. We're here, the queens are here to bust myths, that CGM is for only hypoglycemia. I would say CGM is mandatory for hypoglycemic protection in any scenario. So y'all better be getting on the bus if you have people like that. But do talk us through those standards of care, because there are a lot of people from the standards of care who could benefit. Now, we all queens say you got diabetes, you qualified, but let's talk about those standards of care.
So the standards of care will tell you that if the patient has type 1 diabetes, we put them over here because everybody with type 1 diabetes should be on CGM, because they're all going to be on insulin. And then if you have type 2 diabetes, those are the other people that you definitely want to put on CGM. And then consider CGM in patients taking any type of glucose lowering medications. And we'd throw them all in together and say, whether it be insulin, GLP-1s, or anything else, it's time. And that's what the standards are now saying, is we really need to think about it in all people who have type 2 diabetes. So there's no question for people that are on insulin. We're now saying in type 2 diabetes, all glucose lowering medications, and then use it earlier, because there are tons of studies. There's one that I can think of right away that shows if you give CGM right away, that the outcome long-term is going to be better. And it was compared to a group that several years went by before they were given CGM, and it was harder for them to get to and stay at treatment goals. So you meet the patient, the first thing you do is give them CGM. So, and also to consider using AID insulin pumps, and then use standards of care for all CGM pumps and connected insulin devices using AGP and other reports that we've been showing and we continue to show, so that the healthcare provider can use the data and also teach the patient. Now, I will say that these are ADA standards of care. I want to make one more comment though. As everybody works to getting the healthcare providers much more comfortable for uploading this data, CGM data and utilizing it. I don't want that to be the thing that stops the patient from getting CGM, because we know that on their own, they will make behavioral changes. So I would love every healthcare provider to upload the data, utilize the data, and work with the patient. But if a healthcare provider does not want to do that or cannot do it for any other reason, please get out of the way of the patient and still prescribe the CGM so the patient can utilize it in healthcare.
Yeah. You couldn't have said that better. Don't be the barrier. I've often said that before. You might not be on board in terms of downloading and billing and that kind of thing, but at least get out of the way. Now, I'm going to throw one more of Queen's Pearls out there before I talk to Jen about Medicare. So one of the things that I do, and I know you queens know that I do this, I actually take the standards of care, kind of the verbiage in my head. So that's why we want to go over this more and more again, because I dictate those standards of care, not the whole reiteration, but imagine I have an individual and I know maybe they have hypoglycemia, maybe they have dexterity issues, chronic disease, all persons with diabetes. And what I do is in the end of my note, I say, please let this note serve as an authorization for CGM. As you know, the standards of care recommend the utilization of this. I'm going to communicate that with the patient. These are the goals we're going to accomplish with CGM. Now, if the insurance company does not see fit to cover the CGM, I'll let the patient know that their insurance company is not currently following the standards of care that govern and guide us, and they assume the liability in its denial. So my spicy queen comes out in that. And
Excellent.
so, right? Isn't that, don't you just love that warm fuzzy?
So I'm going to make a smart phrase with all of that in there so I can just pop that into all of my notes. I love that.
Just a little spice. Now, a lot of people say, "Oh, well, Dr. Miller, you're meeting their energy. You're trying to." I said, "No, I am setting the standard. That's what we're trying to do." Okay, enough of my spicy talk. Jen, do us a favor, because standards of care. We talked about those. We're going to use them in our note and be spicy. But Jen, we do know that Medicare coverage of CGM is a little bit different. We're hoping they catch up. They're still making inroads. I would say every year we're better. So please go through the current CGM Medicare guidelines so that way we can be informed of how to acquire this for them.
Sure. So current Medicare policy requires insulin use or problematic hypoglycemia in order to have CGM coverage. So that excludes many GLP-1 only patients, despite the strong evidence of the benefit, including in the study that you did that we heard Davida talk about. So it's a gap between evidence and policy. So in my mind, I'm thinking of verbiage to put in the prior authorization based on what you just said about them not following the standards of care. But for now, if someone has hypoglycemia, we have to document that, and we need to advocate for our patients on a case-by-case basis. If it's not, insulin, with or without insulin, but they shouldn't be on sulfonylureas, which would be what would be causing the hypoglycemia.
Right.
But we need policy to catch up to practice. So any listeners of policy creation, please feel free to advocate. So, but this is for Medicare patients. Commercial insurance does vary. So between plans, and some have sensors covered without insulin. So that comes up a lot. If they don't have to be on insulin necessarily for commercial insurance. And if that's not covered in that case, there's coupons you can get 2 sensors, a 30-day supply for, $75. So one other thing for the Medicare patient just to mention is they actually have to have a visit that's within 6 months, because you send the supply orders to DME, not to the pharmacy, and you have to send your note. So and it has to be within the last 6 months for it to be covered. So that's a reminder. And, we should be seeing these patients more than once a year anyhow, but at least 6 months, and get the census from a DME provider for Medicare. Will not be covered at the pharmacy level.
So the one thing I will say and applaud Medicare about is that if you look at during the pandemic, back then, Medicare patients had to be on 4 injections a day and prove that they were doing 4 finger sticks a day. And since then, during the pandemic, they dropped the 4 finger sticks. The year after, they dropped the 4 injections and said only 1 injection or this hypoglycemia. And almost that was almost more progressive than a lot of our commercial insurances, who have then followed suit and then gone beyond to get to standards of care. So I don't want to beat up on Medicare, because I think they were actually out there in front of this before our commercial insurances. And I would also say, Jen, as I agree with you on the durable medical equipment, but at least in Michigan, some of the Medicares are now allowing the patients to go to insurance, so they can check that. But by and large, you're right. They have to go to DME, and they must be seen not only within 6 months to get their first prescription, but every 6 months to maintain it.
Right.
But there's more to come, and I think that they will be more inclusive as we move forward. Fingers crossed.
Yeah. And Jen, talk to us a little bit about, let's say you have somebody who doesn't have coverage, but really wants to still glean that information, sees the value. We have a clinician, we have a willing person, they want to get that information that's provided. How do you navigate that? What are some of your options, over the counter or vouchers, or tell us a little bit about that.
Yeah. So, it turns out if you actually try to fill a prescription sensor, it ends up being cheaper with the coupon than an over-the-counter sensor. So I think it's wonderful. Anyone who wants to use it, I support them. But writing an actual prescription and having it be denied by the insurance, and then using a coupon, bringing it down to $75, actually ends up being less expensive than over the counter.
Yeah, that's great. And, intermittent use, that's another option that we talk about. Maybe doing it a couple weeks before you come in for an appointment. Well, this has been so informative. Using CGM in addition to GLP-1, it really does provide improved glycemic control. We've seen the data. Not only that, we've seen a real life episode of this. I mean, you're going to see this over and over again. And it doesn't matter where you initiate it, whether you do the CGM first and then the GLP-1, or the GLP-1 and the CGM. We know that the two work in concert. I love it. CGM fills in the gaps. It illuminates what the person doesn't know. And, from the payer perspective, CGM is exceedingly beneficial. We are, if just the payer would jump on board to see how much did I just save them by helping Angie, with her life, like seriously, right? Well, it's always too quick, Queens. We're coming to an end, and we've had just a great opportunity to discuss GLP-1s, reviewing that great case. I can report, I just saw Angie a few weeks ago. She's doing splendid. Still, everything is amazing. We want you to get CME for this. And so please scan the QR code. Remember, we're going to have future Queens events. And, I want us to get our questions going, everyone, because we are planning for a Queen's Court to do some questions and answers. So that you need to get those going ahead of time. We actually got a last minute question and we have time. Okay, I understand at this time that things can be hard for people and doing this to get the CGM. And so they're wondering, how can we help overcome some of those challenges or barriers? You know what? You got to go back to some of our episodes, people. You got to look back at our episodes, because we have great episodes in the archive. Check out our library. Check out the Queen's Library. We have discussion about how to overcome barriers regarding CGM initiation, how to get payers' perspective. So, as always, it's been sweet having sweet talk with my sugar queens. We so appreciate every one of you. We know you're at the front lines. We know that you guys are working hard and caring for individuals. We know many of you are living out there, living your best life, taking diabetes along for the ride. So from myself and my fellow queens, we are so appreciative for you taking part in this activity. We can't wait to see you again the next time. But remember, please bookmark season 2, because we are in season 2 here on YouTube. All of the recordings of the Sugar Queens, all of our great time with our patient last time at the ADA. Ooh, we might hear more from her the next time. So thank you so much for tuning in from myself and my queens. We hope you have an amazing week, and we look forward to seeing you next time.